And if these patients, you see a problem like this, perhaps you may want to perform a bone turnover marker to see whether they are actually severely suppressed. And if they've unfortunately fractured, my experience is that I would not continue the bisphosphonates, and I would use an anabolic agent if I thought that oversuppression was one of the key elements here. Next, osteonecrosis of the jaw. And this is where I think the bisphosphonate companies are having big issues because some opportunistic patients have been taking them to court. What is the criteria? Let's learn from this. The criteria for the diagnosis of osteonecrosis of the jaw is actually very simple. It's not anything fancy or anything like that. It's exposed bone which does not heal despite 6 weeks of appropriate dental surgical debridement or sort of like care in a patient who's had perhaps a dental surgical procedure. Non-healing sort of like dental area that despite after 6 weeks of a surgical procedure, despite appropriate care, i.e. they've cleared off infection, i.e. they've cleared off any other sort of local problem. This is one typical type of case of osteonecrosis of the jaw. Presented as a case, 6-year history of an oncologic process. They've been given multiple chemotherapies that have been very strong and causes immune suppression, multiple doses of IV high-dose bisphosphonates over a very prolonged period of time, has had a recent dental procedure, i.e. surgical extraction or thereabouts, and then they develop osteonecrosis of the jaw. Showing you a few pictures to depict what it might look like. This is what the patient complains of, a non-healing sort of like open exposed area. When they had the debridement, you will see that this is the brownish necrotic area that has not healed, and that's the reason why these patients are not healing. And this is what happens after debridement. There is still a small leftover exposed area. The healing process takes months. So let's learn from this problem. ONJ, when it happens, the prevalence appears to be magnified if they are on very high doses, frequent doses of intravenous bisphosphonates, especially in the background of an oncologic process. And the incidence can be up to 4 to 13%. The treatment of the bisphosphonate tends to be prolonged. But what about when used for osteoporosis? Then the incidence drops significantly. This is a figure taken, and it suggests that it is extremely low. So I would not use ONJ as an excuse not to treat the patients who have osteoporosis, if not particularly with bisphosphonates. Recognize the risk factors for this happening. Patients who have got oncologic processes, especially if they have metastases to the bone, patients undergoing sort of chemotherapy for cancers, invasive procedures, poor oral hygiene, and maybe even localized radiotherapy. However, you might think whenever you see a series, it suggests as if, oh my God, that bone is decaying, it's going to drop off. In general, when you see more cases, it's not as bad as it looks. In this series, they recognize that mild ONJ is the more common presentation of this problem, and that they, in their experience in this Kaiser Permanente database, found a small number, but most of them had bisphosphonates for a relatively long duration. Lesion was generally small, and they thought that perhaps the risk is a lot higher than what I've showed you. What are the reasons behind this? First of all, trauma. Secondly, a patient who is likely to be immune suppressed. Thirdly, but not certainly an insignificant problem, 90% of these lesions, when they actually checked, found infection in that base of that ulcer. And the question, therefore, that is on our minds is whether or not this is a toxic effect of long-term bisphosphonate therapy. Not quite proven. Why is that not quite proven? One more thing that I need to say. ONJ is, again, not the the only domain of exposure to bisphosphonates. ONJ has been recognized by dental surgeons to occur in bisphosphonate-naive patients before the discovery of bisphosphonates. So ONJ is not something that is never seen. They have seen it in normal circumstances. So it is not something that is only seen with patients exposed to bisphosphonates. It happens even in normal circumstances. The next question is this the domain of bisphosphonates? And the answer is no, although I gave you the talk yesterday on denosumab, and their initial denosumab did not show any issues of ONJ when they were used in the setting of an oncologic process, advanced breast cancer, because they were looking at indications for that use. And when they use high doses of denosumab, you will see that they start seeing ONJ in those patients exposed to denosumab. So it is not just the realm of bisphosphonates. It appears to be if you actually oversuppress bone resorption. So what do I do if I have problems with osteonecrosis? The recommendation is try not to do any kind of surgical debridement because it appears to cause a worse outcome. The question is, of course, in your mind and my mind, whether I should stop the bisphosphonate. And it would take a very aggressive and confident person to continue it. But of course, treat the underlying problem and antibiotics for infection. So now let's look at what is the likely sort of lifetime risk for such problems happening. Fracture, if you don't want to treat, say, oh my God, these drugs are so dangerous, they've got so many side effects, I'm not going to treat my patients. Please think again. The overall fracture risk lifetime is 1 in 2 or 1 in 4. The overall risk exposure to any of these drugs, like bisphosphonates, is 1 in 1,000 to 1 in 100,000 or less than 1 in 10,000. So the overall risk-benefit ratio, I hope you don't even have to calculate it in your mind. So next is, how does strontium ranelate work? We've told you about causing a little bit of anti-resorption effect, but the main thing that perhaps you need to look at is they have evidence that suggests that perhaps they have some effect on improving bone formation. So this is the surrogate that they used to decide whether or not they have an effect on bone formation. So with regards to resorption, you will see that in fact the suppression markers dropped. But what suggests that there may be some effect on formation is that the bone formation marker, alkaline phosphatase, goes up, surprisingly, suggesting that there may be some anabolic effect. Going on to microarchitectural advantage, if you have this sort of dual role in the way that this drug works. How about improving cortical kind of bone? In this sort of cartoon, you will see from baseline, if there is any effect on improving cortical bone, this is what you might see. And I will show you the actual amount of improvement of cortical bone, and you will see that here is strontium ranelate in the yellow, green is alendronate, and you will see from baseline there is a significant improvement, and compared to alendronate, again the market leader at that time, you will find that strontium ranelate compares favorably. What about the effect on bone volume and trabecular bone? You will see that, yes, again, strontium ranelate compares favorably against the comparator, which is alendronate in this study. Just to show you what perhaps the microarchitecture, the histomorphometry might look like, you will see that significantly cortical bone can be thicker, the trabecular and trabecular plates are thicker compared to patients on placebo. Let me just run up a little bit faster, right? Here we have the effect on bone volume. In the yellow is the patients who've been exposed to strontium ranelate, and the gray is the patients on placebo. These patients were patients who had been exposed to bisphosphonate therapy for at least 3 years and then changed to strontium ranelate. So one of the key problems or questions that I ask myself is, when I start a patient on strontium ranelate who've been given Fosamax or alendronate in the past, can this strontium ranelate work and not be blunted in its effectiveness? And the answer is here that there has been no suppression of its effect, And in terms of the other parameters, again, you will see that there is significant benefit even if you change the patient from a bisphosphonate to strontium granulate. So in conclusion, I hope I've shown you their data to perhaps convince you that strontium granulate is an agent that you might be able to use in patients over a broad range, whether they're fractured or not, younger or older, whether they're osteoporotic or even osteopenic, that the benefits are seen fairly early on and they are sustained. There appears to be safety in the way it works. In my experience, I have not seen the DRESS syndrome that has been recognized and been published about, but it happens very, very infrequently. And certainly in some patients, they would be considered as my first-line option for therapy. And with that, I think I'd like to show you a similar picture to what JK has shown you. We don't have to look forward to this kind of posture as we get older. I'm certainly very fearful of that. I'm already short enough, right? And of course, why can't we look forward to this? Thank you very much for your attention.
Thank you very much. Can